listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! Hi, listeners. The title of the featured paper in this episode is as follows: Clinically Relevant Extracardiac Findings at Cardiac Imaging, Insights from the European MRCT Registry. The lead author of this paper is Dr. Lucas Moser, and the senior author is Dr. Hatem Alkadhi. So this paper describes a retrospective analysis of over 400,000 different imaging studies from a multinational European registry. Relevant extracardiac findings were found in a little more than 3% of cardiac CTs and about 1.5% of MRIs. Higher prevalence of these findings were seen in older patients and in specific types of indications like TAVR evaluations, myocarditis evaluations, things of that nature. As clinical imagers, we know how much these incidental findings can influence clinical management and require follow-up. So I think it's important to talk with the authors about their dissection of the findings from this particular registry. So I had the privilege of being joined by the senior author of this paper, Dr. Alkadhi, in a conversation. Let's jump into that conversation now. Okay, listeners, welcome back. I am now joined by the senior author of our featured paper, Dr. Hatem Alkadhi. As a reminder for our listeners out there, the title of the featured paper is as follows: Clinically Relevant Extracardiac Findings in Cardiac Imaging, Insights from the European MRCT Registry. Dr. Alkadhi, welcome onto the podcast.
Thank you very much for being invited. It's a pleasure to be here.
Of course, the pleasure is ours. Let's get to know you a little bit better for our listeners. Could you talk to us about where you're currently practicing and what the role in your practice is?
As you said, my name is Hatem Alkadhi. I'm a radiologist. I'm working at the University Hospital Zurich in Switzerland. I work there now since more than 20 years. And the focus of my research interest is cardiovascular imaging with a strong focus on computed tomography innovations. And since 2 years, I'm in the board of the European Society of Cardiovascular Radiology, and I'm there also responsible for the MRCT registry, which we used here for this scientific work.
Excellent. I think that leads naturally then into the paper at hand. Could we discuss a little bit more about the registry itself? How did you yourself get involved in the registry, and what is the function of the registry? Is it specifically for this publication, or are there other things being derived from it?
Well, this registry was installed more than a decade ago mainly driven by Matthias Gutberlet, who is a radiologist from Leipzig, Germany. And this registry was always hosted by the European Society of Cardiovascular Radiology, the ESCR. And it contains a lot of information regarding multimodal cardiac imaging with CT and MRI. It contains no images, so it's really a database with information, but it contains really a lot of information, such as, for example, indications, techniques, protocols, machines, reconstruction types, contrast media protocols, what type of contrast media was administered, potential complications from, for example, contrast media application, and many studies so far arose from this registry because it's a very, very large database with more than 400,000 entries, which is really an amazing number.
Dr. Alkadhi, the paper at hand is regarding extracardiac findings. You had mentioned a variety of different parameters that were collected from the imaging studies. Were reports also collected as to describe these extracardiac findings?
Well, not explicitly reports. They were not uploaded, but the people who entered information into the registry, they had a field like a pop-up, a window where they could enter if there were extracardiac findings, and then they could select: is this a clinically relevant extracardiac finding or is it clinically irrelevant?
Perfect. So I do want to get into that idea of clinically relevant, but let's give an idea to our listeners about what some of those extracardiac findings were. Could you give us a couple of examples in the lung and the abdomen and the other spaces?
Yeah, typical extracardiac findings in a CT or MR study of the heart or cardiovascular systems are pulmonary nodules, pleural effusions, suspicious abdominal lesions that cannot be further differentiated in this respective examination, or also suspicious bony lesions in the thoracic or lumbar spine, depending on the type of examination. These are typical examples.
Got it. And to clarify, these are on both CT and MRI type studies, correct?
Yes, correct.
Are multi-organ system or perhaps multi-body part examinations included? For example, with structural imaging, we often obtain chest and abdomen images as well for access planning. Were those included in the registry too?
Yes, they were included, correct. We included a separate category of patients who underwent aortic valve replacement through percutaneous transcatheter aortic valve replacement. In these patients, they usually require a chest and abdominal CT examination. And these were included here in this work as a separate category because those patients, they had a larger coverage of body volume as compared to a simple, let's say, simple cardiac CT or cardiac MRI examination.
Excellent. Okay, thanks, Dr. Alkadhi. And now, before we get into the results of this specific paper, you had mentioned clinically relevant as the modifier for extracardiac findings. Could you go into a little more detail as to what clinically relevant means in this context?
Yeah, thank you. This is a very good question because the definition of clinically relevant is not so uniform, also in the literature and previous papers, and what they call a clinically relevant extracardiac finding. For example, in a very recent studies by Michelle Williams with data from the Scott Hart trial, they defined the extracardiac findings. They subdivided them into clinically significant and some non-significant findings based on the probability that these extracardiac findings were the root cause of the symptoms. So this is a different definition than that we made. We categorized clinically relevant extracardiac findings as those that require follow-up examinations and those that necessitate a change in clinical management. So this was our definition.
Perfect. So broader, you would say, than some other similar definitions used in the literature. Is that correct?
Yeah, that's correct.
Got it. And you had mentioned before that there are, is it more than 400,000 examinations that are included in the registry?
Yes.
Got it. So extremely large registry, lots of information about extracardiac findings, and specifically mentioning clinically relevant extracardiac findings as those that precipitate either follow-up examinations or follow-up management changes. Perfect. I think now is a good time to get into the results themselves. Rather than try to tease out one or two specific examples of the results, what we would like to hear from you as to what you think the most impactful results were from this particular publication about extracardiac findings in these cardiac exams.
Well, what is the most impactful? This is a very good question. I would say what is here really the thing that differentiates perhaps this study from previous studies on the same topic is that we really make use of this very large database containing information from many centers, from many countries. Almost all European and some non-European countries were included. We have academic centers, we have non-academic centers included, small private practices, as well as large, university hospitals in large European cities. So I think the numbers that we gather from this registry is quite generalizable and meaningful.
Yeah, good to hear, because there are likely many around the world that practice in niche practices, very small academic centers, large private practices, whatever it may be. So some of the data that may currently exist may not apply. In fact, I think you mentioned in the publication the justification for the evaluation of this registry, in that the previous literature on extracardiac findings often derive from relatively small cohorts. Is that correct?
Yeah, not all are small, but I agree with you. They are definitely smaller than these, almost 500,000 examinations that we had.
Okay, something notable for me was that age and the indication of the examination seemed to have a significant role in the prevalence of a clinically relevant extracardiac finding. It may be self-evident, but maybe we can go into that in a little bit more detail. Why do you think that was the case?
Well, I think the age issue, the relationship of age with the prevalence of extracardiac findings is something that we could expect. We had this in mind beforehand. I think this is quite self-evident, and this was clearly confirmed in the data of this registry. I think this is something that we know from our daily radiological business, that the older patients get, the more things we see on all the images. Could be relevant, could be irrelevant, but for example, a pulmonary nodule is, just to take the simple example, is more often to occur in a patient 50 years old than 20 years old, of course. And I think this is what is reflected here in our data. And I think this is but not only something that is confirmed that everybody knows, it's also really also important because we see that the population is getting older. We have a growing life expectancy of the people. We do more and more imaging, and I think this is all across Europe and also all Western countries. Cardiac imaging gets a more and more prominent role also in the guidelines, in recommendations, first-line imaging test for certain indications. So we will have more elderly patients in our machines, in our imaging machines. We will do more and more of these imaging examinations, so we will encounter more and more of these extracardiac findings, either relevant or irrelevant. So therefore, I think this is really, although evident and expected, an important finding.
Dr. Alkadhi, you bring up a great point here where we are imaging more people, and it's a factor, a majority of the Western population getting older, sure, but also access to imaging just appears to be increasing. In fact, the registry data span more than a decade, 2011 to 2023. I imagine even in that time frame, access to imaging has increased. So did you observe any temporal trends in the prevalence of extracardiac findings over those years, or were they static throughout?
This is a very good question. We looked into this quite detailed and more than just one time, because we also expected somehow a trend, but we didn't find any trend over this time. We are not sure why this is the case. Perhaps because a cardiac CT study with a lung reconstruction with a large field of view is pretty much the same as it was, 15 years ago. The pulmonary nodule is the same. So people were smoking also by that time. So perhaps we did expect here too much, but we didn't identify as a clear trend in any direction throughout this decade of observation.
I did notice a trend, if you will, of a higher prevalence of extracardiac findings on cardiac CT examinations compared to MRI. Could you elaborate more on why this might be the case?
Well, there are two aspects here to answer this question. The one thing is when we do a CT study for patients who are planned to undergo transcatheter aortic valve replacement, then that's again clear and obvious that we cover a larger part of the body, so we find more extracardiac findings and potentially more relevant extracardiac findings. So therefore, in this group, we had the largest proportion of extracardiac findings who underwent chest and abdominal CT. So this is one part of the answer. The part of the answer is most probably related to the spatial resolution, or just the resolution of CT to cover the lung. I think we are still, despite of the many advances in MRI, still able to better see also small pulmonary nodules in large field of view reconstructions covering the lung than with MR. And this is the most probable explanation that comes to my mind.
I think this probably matches both of our own practices anecdotally too, that there are far more clinically relevant or even irrelevant incidental findings that are seen on CT compared to MRI. Something that was interesting to me in particular was that there were more extracardiac findings in male patients in the registry than in non-male patients, specifically on CT examinations. Why do you think that was the case?
Yeah, this was an unexpected finding. Yes, I fully agree with you. This was not expected. We had some trouble to try to explain this. One possible reason that came up to our mind was that there could be, more males smoke still, particularly in the last, let's say, 10, 15 years. And smoking causes lung changes, pulmonary changes. And perhaps this is the reason why we observed more extracardiac findings in males as compared to females. But this is just a hypothesis. This is not, it's just speculation.
Yeah, and that last point, Dr. Alkadhi, is a good one, right? That we've observed a variety of these relationships. The fact that more clinically relevant extracardiac findings were present on CT examinations compared to MR, in older patients compared to younger, surprisingly in male patients compared to female. And I think we're really only scratching the surface as to the various relationships that were found in the paper. Rather than dive into each one, perhaps we can ask a more speculative, future-looking question now about what we should do with this information as clinical practitioners, as radiologists. How should we approach this in terms of, say, cardiac imaging protocol design, reporting, management of these findings? Wanted to get your general thoughts here.
I think the radiologists, with all their training, are really in a unique position to handle these extracardiac findings, because we are trained not only on the coronary artery, but we are trained also on the lung and to the bone. I mean, it's part of our structured training program and also board certification and all what follows. So we are really in a very unique position to tackle these findings, and then also to make the right decisions based on, for example, the Fleischner criteria for making the right recommendations. Because we know that we are trained to know that not every pulmonary nodule needs necessarily, for example, a follow-up examination. But since we are trained to do that, this could also help, reducing unnecessary downstream tests, because we are able to differentiate relevant from potentially irrelevant extracardiac findings. And so I think the result of this study in this large registry population strengthens the point of cardiovascular imaging performed by radiologists.
Well, as a counterpoint to that, many places around the Western world and really around the entire world include cardiac imaging that is interpreted by non-radiologists. So that is human interpreters, cardiologists, and my cardiology colleagues, but also in the future in particular includes non-human interpretation. Wanted to get your thoughts on how non-radiology interpretation may play into this data that we have about the relationships of cardiac CT and clinically relevant extracardiac findings. And I don't mean to bring up a diplomatically prickly topic, but I think it is important to discuss.
Yeah, it's a big topic that you address here. When I just look at my daily clinical work, where we do more and more examinations, CT examinations from back to toe, from many, many indications, the time slots getting shorter, the sequences get faster, also in MRI. So then I think it just simply looking at the workflow, I think there is no professional better suited to look at cardiovascular imaging plus extracardiac findings than the radiologist, because this is just one person checking all these findings in the heart, around the heart, in the liver, in the lungs, and so on, and then making useful recommendations. Just simply when looking at workflow issues, I think no other professional is better suited for doing so. When you have a cardiologist, or let's say a non-radiologist, looking at the coronary arteries, and then you need another board-certified doctor, a radiologist, for looking at the lung, I think this is not efficient in a busy environment.
Okay, Dr. Alkadhi, thanks for your insights there. I want to start coming to the close of our conversation and ask about the future of this specific registry. Are there any other ideas for what you'd like to demonstrate about extracardiac findings from this registry, or maybe more broadly, are there any other future steps for data from the registry itself that we can anticipate in the near future?
So first of all, what is perhaps important for the reader, the registry data can be accessed by every radiologist. Every radiologist could write an email to me or to the Office of the European Society of Cardiovascular Radiology. It's open to ideas. When somebody has a good idea what study could be done, somebody has, something certain idea in his mind regarding temporal trends over the past 10, 15 years, Do they reflect, for example, guidelines that came up? What are changes in indications, in practices? So first of all, that this registry is open for everybody who has good ideas, and then we can meet and we can discuss, and then we can make a plan for pursuing this work together, first of all. Beyond that, we are currently discussing an expansion of the registry to also non-European countries. And again, everybody is welcome to add data, to participate in this registry and also make use of it. And we are also continuously refining, of course, the entry categories, because radiology is such a rapidly evolving field with so much new technology. Every second year we have new CT scanners around now with photon counting detector CT, for example. We need this new category, in our drop-down menu in the registry, which is not yet there. So we have continuously to refine, all our entry fields, and we want to expand also to non-European countries. And everybody who has a good idea is welcome to contact me or the ESCR office, and then we can discuss on good ideas.
Fantastic. Dr. Alkadhi, it's a living registry. It's not static in that sense. And there's always room for new scientists and new participants to include their information and data and insights as to how to dissect this data. Very cool. Well, wonderful. Dr. Alkadhi, thank you very much for coming onto the podcast and sharing your insight and time. Work is, of course, extremely meaningful for a clinical radiologist like myself. This is fascinating to see on a more population level, because it's really hard for me to dissect population level information on my day-to-day practice. So thank you from me, from the journal, and from the entire cardiovascular imaging world. Really appreciate it.
Thank you very much. It was a pleasure.
Of course. Thanks again, Dr. Alkadhi. To our listeners, I encourage you to get out there and read the paper, which is available in the journal right now online. In case you are interested in hearing more content like this from brilliant minds like Dr. Alkadhi, please rate, review, and subscribe to the podcast. That helps others out there find this type of content. This is the Radiology Cardiothoracic Imaging Journal podcast. We will see you next time.